कैन हियर यू एंड कि कोई बात नहीं स्टार्ट करते हैं करो
ये तो पूछ लो कि स्लाइड्स
स्टार्ट
दिख रही
कर
हैं?
हाँ दिख रही
स्क्रीन ही कर दो।
तो फोन में जाएगी
तो आपको पता भी तो चलना चाहिए कब स्टार्ट करना
नहीं
है।
नहीं उसका स्टार्ट कर दो करूँ
कॉल आ रहा है, कॉल नहीं।
हेलो उसको भी तो दिखाना था ना उसने कुछ मैसेज करना उसकी स्मूथ
वो नहीं आ रही ना, तभी तो मैसेज करने बदल में और मेरा क्या
Hello. Good evening, everybody. I'm Dr. Rakesh Mahajan, Principal Director and HOD, Department of Orthopedics at VLK Max Super Specialty Hospital, New Delhi. Today, I will be putting some insights in the recent innovations on the total knee replacement surgery. Total knee replacement surgery has been there for the last 3-4 decades, and since then, many innovations have been coming over. These include initially we used to have a universal implant, means there was no right or left knee implant. When I started my practice, we started with universal knee replacement in 90s, and patient used to have a certain sound of patella striking against the femoral component. We used to call it patellar clunk, tuck, tuck, something like that. But over by the end of 97, 98, we had right and left knee and gender knee implants, which solved that problem of patellar clunk. And since the female knees are comparatively smaller in size as compared to the male, and plus different races have different sizes, especially the Europeans and the Africans have longer size knee implants compared to Asians, especially uh, Indians and Indian ladies. So we have brought over the time there have been different innovations in different sizes. Means now one size is not there for everybody. We have different sizes and they are placed at difference of 5 mm difference. One different companies number it as 1, 2, 3 or ABCD depending on their choice. So starting with the introduction today, total knee arthroplasty has been a well-established treatment modality for severe OA knees. Since we have four stages as compared as radiological classification, where there is denudation of the cartilage, articular cartilage, plus there is degenerative wear and tear of the ACL as well as the menisci, and that is the stage when the bone becomes raw, articular bone becomes raw, the cancellous bone becomes raw, and it starts rubbing against each other, and patient can present with pain, effusion, knee effusion, and patient can present locking of the knee because of the meniscal tear or anterior cruciate ligament tears. So it is a well-established modality for stage 4 or severe osteoarthritis of the knee. For stage 1, 2, and sometimes for stage 3, we have different established treatments called the cartilage regeneration or cartilage preservation modalities, treatments, and they are holding their own ground very well, and patient can improve with those treatments. But now we are talking about the stage 4 or the severe osteoarthritis knee. Aim is always to restore pain-free, functional, and durable knee joint. The results have good survival rates. Initially, second generation knees we used to tell that the survival rate will be around 12 to 15 years. Now we are getting more younger and younger physically active patients which are undergoing knee replacement. And because of active physical life, or because of certain change in lifestyle, or because of increased sports activity, or other increased gym activities, or other activities, patients are now getting degeneration at a younger age, and patients are well aware that they have to be physically active, so they are opting for total knee replacement in stage 4. But overall, has been observed that 20% of the patients who have undergone total knee replacement are and remain unsatisfied. They have some or the other complaints, and it is the duty of the surgeon to look for if there is a any problem with the quadriceps strength, or if there is a any problem with the degeneration of the lumbar spine, lumbosacral spine, which is causing radiculopathy. Hello. No, I know I'll move slowly, but I'm not only on the this thing. I'm giving a general add-on from my side. Okay. So the now the present need is always, and it will always remain, for a better knee alignment for long-term survival. Now we actively say the present day implants can survive up to 25 to 30 years. There has been changes in the implant contour. There has been change in the plastic. We now have the very high molecular density polymer, which has a good survival rate. And there have been certain other additions like uh, vitamin D injection in the uh, plastic, which enhances the life of uh, the plastic. Now the latest innovations we have is the robotic assisted systems. Say the navigation systems. This is part of the evolution of the navigation systems, which started some 2 decades back. And over the time, there has been improvement in the system, and now with the other engineering industries where robot is being used constantly. Now we have the robotic assisted systems in knee and hip also, as similar in the other specialties like in cancer or in urology department. Now multiple specialties are using the robot systems. In orthopedics, especially, we have the spine, or the spine and the knee and hip. It is not the robot who is doing the surgery. It is the robot assisted systems, which they are becoming popular because they produce a very ideal 3D model during surgery, which allows accurate bone cuts and palpation and placement of the implants. But it, it is a it is important to note that these all these innovations have some limitations. We'll discuss it later on. Coming to history of innovations, first important is how the long-term survivalship depends on what factors. It is the implant positioning. It means there should be contouring of the exact contouring of the implants. They should be aligned well. That comes with the limb alignment. See, normal valgus is knee valgus is usually 3 to 5 degrees, and that has to be maintained. And if there is a varus, then there will be implant wear and tear, and implant loosening will be there, which can decrease the survivorship of the implants. Next is the implant sizing. It is very important to have a proper size of the implant. For the if it is a mega implant, then again the implant positioning will not be good, and there will be definitely, it can cause notching, and it can cause wear and tear of the patella, which can cause a stiff and painful knee joint. So a proper implant sizing is very important. Then there should be a minimum soft tissue damaging. This is very important since we have multiple approaches for the knee replacement. The commonest is the parapatellar approach, and then the mid-vasters and the sub-vasters. I am a surgeon who uses mid-vasters approach. It is an excellent approach and gives a very minimal damage. And the beauty is that after mid-vasters approach, the recovery is very fast because I'm not cutting the quadriceps tendon. I'm not splitting the quadriceps tendon. I'm just splitting the vastus medialis muscle. And in lean and thin people, we can go for the subvastus approach also, where we raise the flap of the for hold the muscle, and it is an intramuscular approach. Then the last important factor is the ligament balancing. Ligament balancing is very important in both flexion and extension, and it has to be accurately done. Otherwise, there will be mismanagement, mismatching of the implants, and there will be a pain and stiffness, and early wear and tear of the implants, and implant loosening will be there. So, coming to the traditional methods where we have mechanical zigs and guides, they help us to achieve the mechanical alignment, that the mechanical axis. With the help of these, over for the last so many decades, we have been using them, and over the years, the companies have initially, yes, they used to have mega mechanical zigs. Now they have come with very micro or mini zigs, which are quite helpful and not bulky, and they are very easy to manage during surgery. And by that, we achieve the mechanical axis, means the 5-degree valgus. Once, however, the bone cuts are made with these eggs, the final position of the implants depends on the skill and judgment of the surgeon. It is the surgeon's experience which matters in implant sizing, implant positioning, and the most important is the ligament balancing. So, this total knee replacement surgery is a soft tissue ligament balancing surgery. It is the medial collateral and lateral collateral balancing in flexion and extension, which is important, including mid flexion. These parameters are very important for the long term survivorship of the implants. A improper implant placement has been reported in 10% of the cases with the mechanical jigs. Now, innovations are coming because these we have to correct these. We have to achieve those unhappy patients. How to do it? The the innovators have been thinking and undergoing so many improvements so that they get a better results and the lesser number of unhappy patients. First, it's about 2 decades back, it started with patient specific instrumentation zigs. It came around, I started using them in 2007 or 8 when the first Striker came with the patient specific instrumentation. And this is a system which is CT scan based, where preoperative 3D CT scan planning is done for better mechanical alignment. If you These are the patient specific zigs, where we used to, instead of the mechanical zigs, we used to use this. And in this use, it was very important not to take off any osteophytes, any soft tissue releases, because otherwise the ligament balancing will not be achieved. It was very important not to remove any osteophyte, otherwise the zigs won't be effective. However, various meta-analysis studies noted no significant differences in the hip knee angle outliners in the mechanical axis as compared to the mechanical zigs. Again, no study demonstrated any difference in the clinical or functional outcomes of the total knee. Customized implants aim to optimize bone implant fitting. However, a 3D model is used to fabricate a customized implant. Now we have customized implant. Customized implant means it can be done 3D preoperative 3D sizing, and then it takes few months or a few weeks to prepare that special size. Till then the implants are ready, then one can plan for surgery. Again, few studies are available to compare the results with the standard implants for the customized implants, but some of them found no significant difference in the clinical outcome of customized implants compared with the standard implants. But some reported improvement in chronic pain, stiffness, and laxity. Some studies did say that these factors were these irritation points were addressed. Coming to the most important factors in total knee replacement, ultimately, once you are made the cuts and once you using any of these, whether you are using mechanical zigs or patient specific zigs, ultimately the final answer is the ligament balancing. The ligament balancing is very essential for successful TKA, for the longevity of the implants. Otherwise, there will cause mismatch and uh, is aseptic loosening of the implants because of the excessive loading or on one of the compartments. And now with the mechanical zigs, this ligament balancing is dependent on the experience of the surgeon. It depends how experienced the surgeon is, and there is a difference between patient posterior stabilized implants as well as cruciate retaining implants. The one has to learn over the years how to balance the CR implants or PS implants. There is a slight difference, and it takes years to achieve that. So for the younger patients, it's a dilemma. So idle ligament balancing still remains unaddressed with the mechanical zigs or implants. So whereas different factors affecting the ligament balancing include patient obesity, patient gender, generalized joint laxity, degree of joint contracture, plus the surgeon's experience. As mentioned, poor ligament balancing can cause instability and stiffness, leading to patient dissatisfaction, and patient may go for TKA revision, total knee revision, which is not a very rewarding surgery, I would say. Considering these factors, we came through navigation systems, computer navigation systems, and the latest, definitely, we have the robotic assisted systems which have come. Every company has come with the robot assisted systems. Initially, they started with navigation system, which was there for the last 6 7 years. Now, the latest generation is the robot assisted systems, which register pre-operative laxity of the joint, evaluate it after the bone resections are made during surgery, and once the implants are positioned. So kindly note three things. Preoperative laxity, one can judge on the before surgery, before opening up, on the table. And once you have made the cut, you again evaluate the bone cuts and look for the laxity in both flexion, extension, and mid flexion. And once again, again you can check on this monitor the once the implants are positioned and how is the position laxity, ligament laxity in all the three positions. The purpose of sensors is to give objective data on soft tissue balancing during totally arthroplasty. It facilitates decision making regarding implant position and soft tissue release to improve balancing and stability. So once understood that longevity of the implants, stability of the implants depends on the ligament balancing. So robot assistance is very helpful because it helps in judging before surgery, per surgery, and after implant position have been fixed. Considering this, the results reported by 7 studies on robot-assisted systems in a prospective cohort of 50 robotic-assisted PKA Song et al. Reported that 74% of knees needed additional rebalancing procedure with the sensor, means with the robotic, once one after the surgeon has done the conventional gap balancing. So if you can see, nearly three-fourth of the knees needed rebalancing. So that's a very important factor. It's not a, means a, not a factor which has to be neglected. Again, Cho Press and Breslow reported better clinical scores and range of motions after robotic assisted total knee A. Seller et al. Reported reduced knee stiffness. Song et al., however, reported in the long term no clinical and radiological difference between robotic assisted TKA and conventional assisted. So you will come across various studies where you'll get confused. Why go for totally robotic assisted TKA instead of the conventional? When some studies are saying there is no clinical and radiological difference, but using the robot in the long run, especially in difficult patients, helps to improve the ligament balancing and the longevity of the implants. So, long term clinical follow ups are still needed to assess the benefits of robotic assisted system. These systems have been there for the last 2 3 years. Initially started with one, two companies. Now we have multiple companies, or most of the companies which have come with their own robotic assisted TKA. But one thing to be noted is robotic assisted TKA lacks the feeling of joint compartment pressures in varus and valgus strains, right? Another innovation is accelerometer. It was developed to improve the alignment of the femoral and tibial components. That is the mechanical alignment. An error of 3 degree plus in the varus or valgus alignment can have serious consequences in the kinematic alignment. Kinematic alignment is means alignment by the computer navigation. Mechanical alignment is by the mechanical implants, ZIGs. It is a handheld navigation device that displays the data on pod during surgery. Results in meta-analysis showed increased accuracy in the coronal, femoral, and tibial angles (HKA angles). However, no studies have shown better functional knee scores compared with conventional techniques. So, still, the fraternity is confused, but still, we have a choice. We have a choice to learn the understanding of the robotic assisted TKA instead of the conventional. Conventional we have been doing for decades, I feel. And now, with the availability of cash, computer assisted, and robotic assisted systems, why not go and pick them for the betterment of the ligament balancing? This accelerator system has its own limitation. It sits only in component alignment, but factors like sizing, rotation, ligament balancing still depends upon the surgeon's experience. But one point to be noted is it can be a very effective tool in complex cases with extra-articular deformities. Means extra-articular deformities if the deformity of the, because in the femoral cut system we use a intramedullary zig, which is not possible in a extramedullary deformity, old fracture of the distal one third or one fourth of the femur, where it will be difficult without the use of navigation system or the accelerator. The where the deformity is more than 20-degree angulatory deformity is there. So that is a good tool, especially in complex total knee replacement with extra-articular deformities. This is the accelerator, which doesn't have any sensors. It has simple sensors where you don't have to add any extra sensors for Bluetooth navigation, and it gives a direct reading whether the alignment, the mechanical alignment is within HK normal range or no, acceptable range or no. Coming to the robotic assisted knee arthroplasty in detail. This system evaluated from computer assisted or navigation assisted systems. It provides accurate and reproducible bone cuts, the ligament balancing according to bone cuts and implant positioning during surgery is reproducible. But the aim is not to replace the surgeon, but to improve the performance of the surgery. These general principles of robot assisted robotic surgery, these can be the robots can be image guided surgical planning or image free surgical planning. So companies have come with different types of robotic planning. One used surgical planning with the guide, image guided, and one with image free. What is image guided? Image guided means a 3D reconstruction is created pre-operatively to template the component size and 3 positioning. So a 3D reconstruction is made using the pre-operative CT or MRI of the image of the knee, hip, and ankle to determine 3D mechanical femoral tibial axis. And we now have the image free surgical planning where we don't need any pre-operative 3D reconstruction using the CT or MRI of the knee, hip, and ankle. In the image free surgical planning, it registers during surgery the anatomical surfaces of the bone and creates a 3D virtual model of the cuts. Again, robotic system can be autonomous, semi-autonomous, and passive. Autonomous is where the robot is doing most all of the cuts. Only the surgeon has to open it and plan it. Even the ligament balancing, up to the ligament balancing, the this robot is doing. In semi-autonomous, it is the surgeon who holds the probe and does the cuts. So autonomous and semi-autonomous systems help to safeguard against the removal of bone beyond the 3D plan. The autonomous and semi-autonomous systems, they make a cut up to pre-planned 3D image. Even if you try to cut it beyond it, it will not work. The probe will not work. It will not cut. The autonomous systems are available by one Roboto from USA and Casper from Germany. Semi-autonomous systems by Mako, Stryker, Navio, Smith and Nephew, and Rosa Zimmer. I'm using the Navio system by the Smith and Nephew, where it is image free. This system is the Navio is image free, whereas Mako needs the pre-operative CT or MRI. In the passive system, the bone removal is also done by the surgeon. Only the ligament balancing is done by the robot. So these systems, all the systems register ligament plan balancing pre-operatively, per-operatively, and at the end of the procedure with the implants already placed in situ. It is the ligament balancing which helps to achieve good functional outcomes and normal knee kinematics. These systems incorporate soft tissue balancing algorithms. They have multiple algorithms and they have algorithms both for unicondylar knee replacement and the total knee replacement systems. And another important point is with the mechanical systems or the earlier systems, it used to be a nightmare in mid flexion balancing. Mid flexion balancing, what happens in mid flexion balancing? The medial femoral condyle, it slides backwards and it causes imbalancing. But with the help of robotic, it helps us, the surgeon, to balance the knee in mid flexion also, which is otherwise very difficult to assess during the conventional surgery, the earlier conventional surgery. But certain factors remain unanswered with the robot also, and it may take few more years or decade for to do the ligand balancing values in varus and valgus stress, where we measure it measures the varus pressure, I mean compartmental pressure in varus and valgus. So still the varus and valgus balancing still depends upon the surgeon's experience plus intraoperative factors. To assess the results, Kalyani et al. Reported reduced bone and periarticular soft tissue injury with better joint restoration with the robotic assisted TKA. Still, the lacunae. Several case control studies, however, reported inconclusive results between robotic assisted and conventional TKA. So we need some more time to be more confident with the robotic-assisted TKA. So these are the various systems. This is the Mako by Stryker, which uses the image sensors, image guided. To conclude the recent trends, new techniques in TKA are constantly evolving. They have helped to expand the surgical indications, improve knee biomechanics, and restore the native knee function and anatomy. The present day, now everybody is talking about the artificial intelligence and predictive modeling algorithms may be the latest, which can help to incorporate the certain factors which I explained are unanswerable in varus and valgus stresses, where the loading of the medial or lateral compartment is still not reported by the present day robotic assisted systems. Thank you. Any questions, please? Hello, hello. Yes, I'm. Yeah. Any questions? Yes, sir. We have received few questions. Yes. I'm sharing over your WhatsApp. Okay. Yes. Okay, sir. The question is how the adoption of robotic assisted knee replacement surgery impacted surgical outcomes and patient recovery times. As mentioned, initially you have a learning curve for the robot assisted knee replacement. See, I finished my replacement with the conventional zigs and mechanical zigs, mostly 20 minutes or 30 minutes. The placement and sitting is done. But with the robotics assisted initially it used to be double the time or sometimes more. Now with the learning curve, you learn the ifs and buts and you are able to achieve the excellent results, and the the impaction will be there after few decades, I would say. What are the present surgical outcomes? Let's hope for the best, because otherwise the patients are more pain free and they have a better functional outcome in the 6 to 1 year or 2 years follow up which we have been doing. Second question is, what criteria do you use to determine if a patient is a candidate for minimal invasive knee replacement surgery? Yes, for the minimum invasive knee replacement surgery, one has to see whether the patient is not obese, say means BMI is not more than 30, and where you can't uh, I mean, squeeze everything a in a bigger fat, this thing. And the other thing is, if you have the deformities, the soft tissue contractures, where where is there's a lot of bone loss. Sometimes there is a medial compartment bone loss of the tibia, where you have to add on the bone or some other things. Then you have to increase these. Uh, you can't do minimum invasive knee replacement. So these are the criteria where you are not able to do. These are rather secondary criteria. Where the deformity and contractures and the obesity is within range, then you can do always go for a minimum invasive knee replacement. Next question is, what advancements in imaging and pre-surgical planning have contributed to the effectiveness of PSI? I think patient-specific innovations advancement is that the now the radiologist is able to uh, read the HK angles in the CT scan very well. Plus, we have bioengineers which can plan it beautifully. Now we have a special class of engineers, bioengineers, which are now attached with these companies, and they are on the research side, and they are available preoperatively for the PSI zigs, which help in making a 3D print before surgery. So this is the new innovations which are available. Every company is having these engineers, and what we do is we take a CT scan for whole limb, the whole lower limb, and send it to the company for the uh, planning, 3D planning, and they come up with the. It all started with the PSIs. Now again with the image guided robotic assisted, it is the same. The only thing is that in the PSI, it used to take 6 to 8 weeks for the patient from the company. Now with the robot assisted, it is available the next day or the third day. That is the beauty. There is a lot of time saving. Are there any emerging biological treatment that show promise for improving knee replacement outcomes? The biological one I mentioned was that we have been adding vitamin E to the plastic, and that increases that reduces the wear and tear. I mean, the free radicals are decreased. We call the free radicals wear and tear means free radicals. The wear and tear is less, and longevity of the plastic is good. The now we have the gold plated implant where the longevity is improved by another average 5 years. What are the potential benefits and limitations of using 3D printed implants in knee replacement side? The potential benefit is that you get an exact size, which helps in preventing any stiffness, knee stiffness, and pain, which improves the confidence and the soft tissue. Uh, I mean, behavior is much better with the exact implants, 3D printed implants. That is the beauty. And earlier, what used to be there, the implants used to overhang, and it used to rub against the patella or rub against the tendon, patellar tendon or quadriceps tendon, and used to cause uh, pain and irritation and tendinitis, tendinosis. And those used to be the, I mean, the flare points which patient make used to make the patient unhappy. I hope I have answered the questions. Hello. I hope I've answered the questions.
Yes, sir. Yes, sir.
Hmm.
Thank you so much, sir,
So,
for
right.
and we have faced so much difficulty in this session. I don't know why.
Mhm.
Okay, sir, I'll share the report with you. Okay.
Oh, okay.
And the recorded session link. Thank you so much, sir, for
Okay.
your time.
Thank you. Okay.
Thank you.
Thank you. Bye.